Hello everyone and welcome to our video on Down syndrome. If a fertilized egg has 3 copies of one of the chromosomes, that's called a trisomy, and most trisomies are not compatible with life and will lead to a miscarriage. However, there are a couple of trisomy disorders where the baby can potentially be carried to term and sometimes survive after birth, and the 3 main disorders for which that's the case are Down syndrome, which is trisomy 21, Edwards syndrome, which is trisomy 18, and Patau syndrome, which is trisomy 13. We'll talk about these other 2 in another video, but in this video we're going to focus on Down syndrome, which is the most common trisomy disorder and something that you're likely to see in clinical practice. Down syndrome is the most common live-born chromosome abnormality, and the word live-born is important because among fertilized eggs in which there is a miscarriage, there are many other chromosomal abnormalities which can be found. Down syndrome is also the most common form of intellectual disability. Other key features of Down syndrome, which we'll go through on the next few slides, include what's known as dysmorphic features. These are basically abnormal features of the face and extremities. This includes the face, hands, and also the stature of the child with Down syndrome. Congenital malformations are also common in Down syndrome. We'll talk about those. These include the heart and the GI tract. People with Down syndrome develop early Alzheimer's disease, and they also have an increased risk of malignancy. And you should be aware that the clinical phenotype of Down syndrome is highly variable. There's a range of features from mild to severe. Some people with Down syndrome are highly functional and other patients are severely limited. Let's start by talking about the dysmorphic features of Down syndrome. Children with Down syndrome are often described as having a flat facial profile. If you look at this picture on the screen here, you can see that this baby's face just looks relatively flat relative to normal. In addition, they have a flat nasal bridge. So this is the nasal bridge. It's the portion of the nose between the eyes. And if you feel your own, it's probably kind of risen up a little bit. It's flat in babies with Down syndrome. Down syndrome children also have low set small ears, like this drawing on the screen, and a short neck. And then finally, they have what's described as brachycephaly. This is the posterior skull being flat. So you can't see that in this picture of this child. But if you could look at this child in profile, you'd see the front of the face is rounded, but the back is relatively flat. You can Google and find pictures of this, and that's brachycephaly, which is common in Down syndrome. There are several classic abnormalities of the eyes that can be seen in children with Down syndrome. The first one are prominent epicanthal folds. So the epicanthal folds are the skin of the upper eyelid that covers the inner portion of the eye. I'm marking my pen with it on this zoomed in image on the screen here, and these are prominent in children who have Down syndrome. Also in children with Down syndrome, the palpebral fissures are upslanting. The palpebral fissures are the separation between the upper and lower eyelids. Normally they are horizontal. However, as you can see in this zoomed in picture, the outer corner is higher than the inner corner, and therefore they are upslanting in this picture of a person with Down syndrome. Brushfield spots are another characteristic finding of the eyes in Down syndrome. These are white spots on the iris. This baby has it in this picture here. I've zoomed in on the right side of the screen so you can see the white spots on the iris. Those are Brushfield spots. Children with Down syndrome often have short, broad hands, and then there are 2 classic findings in the hands and the feet that you should know about. The first one is called a transverse palmar crease. This is a crease that goes across the palm. I'm circling one on the right side of the screen with my pen. This is a classic finding in children with Down syndrome. In the feet, the classic finding is a sandal gap. This is a space between the first and second toes, as shown in this picture here. This is the separation that would occur if you were wearing sandals. That's how it gets its name. Other physical features you should be aware about are hypotonia, so the muscle tone is often decreased, and this can often be identified shortly after birth in children with Down syndrome. And then as children with Down syndrome grow up, they often have short stature and are short for their age. Intellectual disability is another hallmark of Down syndrome. Almost all patients are affected, although there's a wide range of cognitive impairment. A normal IQ is 100 or greater. Children with mild Down syndrome can have an IQ of about 50 to 70. Children with a more severe case can have an IQ of 20 to 35, and this will obviously have a big effect on the type of services these children need as they grow up. Congenital heart disease occurs in 50% of patients who have Down syndrome. Most commonly, these are defects that result from abnormal formation of the endocardial cushions. In the cardiology section in the embryology video, I talk about the endocardial cushions in detail. They are embryologic structures that form the septum between the 2 atria and the 2 ventricles. If we look at this picture on the screen here, this is the right atrium here and the left atrium here. We have the left ventricle here and the right ventricle here. The endocardial cushions form this section of the heart right in here. So if they are abnormal, you can get an ASD at the bottom of the interatrial septum. That's called a primum ASD. You can also develop a VSD right here. And in addition, the endocardial cushions contribute to the formation of the mitral valve. So if there's an endocardial cushion defect, you can potentially develop mitral regurgitation. And I've summarized that here. The endocardial cushions involve the atrioventricular septum. They form the base of the interatrial septum and the upper interventricular septum. So common defects that can be seen in Down syndrome, as I mentioned before, are defects that involve the atrioventricular septum that comes from the endocardial cushions. So this includes a primum ASD or a VSD. And remember that a VSD can cause a holosystolic murmur, and this is high yield for you to remember, especially for the boards. If they describe a baby with a holosystolic murmur, they may be describing a VSD that can be seen in Down syndrome. Gastrointestinal anomalies are also common in children with Down syndrome. They occur in about 5% of patients. The most common congenital anomaly is duodenal atresia or stenosis. I talk about this in more detail in the GI section. In addition, children with Down syndrome are more likely to develop Hirschsprung disease than the general population. Most patients with Down syndrome will eventually develop Alzheimer's disease, and in addition to being common, it occurs earlier in patients with Down syndrome than in the general population. In patients with Down syndrome, the average age of onset of Alzheimer's disease is in the 50s. In the neurology section, I discussed the pathophysiology of Alzheimer's in detail, but I just want to mention that amyloid precursor protein, which is a very important pathologic element of Alzheimer's disease, is found on chromosome 21, and patients with Down syndrome have 3 copies of chromosome 21. Amyloid precursor protein breaks down to form beta amyloid, and amyloid plaques are a pathologic element of Alzheimer's disease. Children with Down syndrome also have an increased risk of malignancy, especially leukemia. The lifetime risk of leukemia is about 1 to 1.5%. It often occurs in childhood. Children with Down syndrome can develop acute lymphoblastic leukemia. The risk is 10 to 20 times higher in Down syndrome children than in the general population. They can also develop acute myeloid leukemia, and they develop a very unique subtype. It's called the M7 subtype. It is a megakaryoblastic leukemia made up of leukemia cells that resemble megakaryocytes. Let's talk about the genetics of Down syndrome. In other words, why do babies with Down syndrome develop with 3 copies of chromosome 21? Well, the most common reason is a meiotic non-disjunction, and I talk about this in detail in the video on meiosis. When this happens, the baby receives 2 chromosomes from one parent and 1 from the other. This is the most common cause of Down syndrome. It's responsible for 95% of cases, and in 90% of cases, the error is in meiosis 1. In addition, the extra chromosome comes from the mother in 90% of cases, and for this reason, Down syndrome is associated with advanced maternal age. In the video on meiosis, I discuss how that process is protracted in females and often frozen in place for many years of time. For this reason, the more advanced the mother's age, the longer it takes for meiosis to complete in the egg, and therefore the greater risk that there can be a problem in meiosis that leads to trisomy 21. In cases that are not associated with meiotic non-disjunction, one of the potential causes is a Robertsonian translocation. I also talk about this in the video on meiosis. This is responsible for 2 to 3% of cases of Down syndrome. In a Robertsonian translocation, chromosome 21 is fused with another chromosome, most commonly chromosome 14 or 10, and because the 2 chromosomes are fused, 2 copies of chromosome 21 can be passed to the fetus from one parent. Now, this problem is different from meiotic non-disjunction in that it is not associated with advanced maternal age. What's unique about a Robertsonian translocation is that the fused chromosome can be passed through families, and therefore there is a recurrence risk for Down syndrome within families. So this is especially important for a board question. If you see a description of a child born with Down syndrome, and there are a number of family members in the extended family who also have Down syndrome, you should think about the possibility that a Robertsonian translocation may be the underlying genetic cause of Down syndrome in that family. Another rare cause of Down syndrome is a mitotic error. So this is an error in mitosis, not meiosis. In this situation, the egg is fertilized normally with 2 copies of chromosome 21. However, in early development, during mitosis, a cell develops which has 3 copies of chromosome 21, and it will continue to replicate, making more cells with 3 copies of chromosome 21. This will result in somatic mosaicism. Mosaicism is when some cells have different numbers of copies of chromosomes compared to others. So in this situation, when there's a mitotic error, the child will have some cells with 3 copies of chromosome 21 and other cells will be normal. This can lead to milder features of Down syndrome, as you can imagine, because some cells in the body have the normal numbers of chromosomes. And this is also not associated with advanced maternal age. This is a sporadic error. I'll finish this module by talking about prenatal screening. In other words, ways to screen pregnant women for the possibility that their baby may have Down syndrome. The definitive test is to obtain a sample of the fetal cells and do a fetal karyotype, which means determining the number of chromosomes in the baby. The problem with this screening test is that it is invasive and carries risk, so you only want to do it when there is a high probability that the baby may have Down syndrome. There are two ways a fetal karyotype is commonly done. One is called chorionic villus sampling. This requires taking a sample of the placental tissue. The other way is an amniocentesis, which involves inserting a needle into the amniotic cavity and taking a sample of the fluid, which contains some cells from the baby. So when you do a karyotype, you create a karyogram, which is a picture of the chromosomes from one of the cells. And this is a normal karyogram. You can see that there are 2 copies of all the chromosomes. And here is a karyogram from a baby that has a trisomy. You can see that for one of the chromosomes here, there are 3 copies, and that is abnormal. So because karyotyping requires an invasive test, there are several non-invasive tests which are usually done to determine the likelihood that the baby may have Down syndrome, and only in cases where the likelihood is high is the non-invasive test followed up with a karyotype. The 2 non-invasive tests that are commonly used are an ultrasound of the baby and maternal blood testing or serum testing. In the first trimester, there are several findings on fetal ultrasound that are suggestive of Down syndrome. The first one is the presence of small, poorly formed nasal bones. We talked before about how children with Down syndrome have a flat profile and a flat nasal bridge, and you can see some of those features on a fetal ultrasound. The second characteristic finding is nuchal translucency. This is fluid under the back of the neck. This is a picture showing nuchal translucency on the screen. This is the back of the neck here, and there's this black space that represents fluid, and if that is seen in a first trimester ultrasound, that is suggestive of Down syndrome. In addition to fetal ultrasound, there are several pregnancy-associated substances whose level can be measured in the maternal blood, and if the levels are high or low compared to normal, this can suggest Down syndrome is present in the fetus. There are different substances that are associated with Down syndrome in the first trimester and the second trimester. In the first trimester, the 2 substances whose levels can be measured to screen for Down syndrome are the level of pregnancy-associated plasma protein A, or PAP-A, and the free or total level of beta-HCG. PAP-A is a glycoprotein produced by the placenta, and lower levels compared to normal are found in pregnancies with fetal Down syndrome. Beta-HCG, as you may know, is a hormone produced by the placenta, and levels are higher in pregnancies that are associated with fetal Down syndrome. In the second trimester, there are 4 substances that can be measured in the maternal blood to screen for Down syndrome. This is often called the quad screen. The first 2 are alpha-fetoprotein and estriol, or it's sometimes called UE3. Levels of these 2 substances are reduced in pregnancies with fetal Down syndrome. AFP is a protein produced by the yolk sac and liver, and estriol is an estrogen. And just a note here, increased levels of AFP are associated with neural tube defects, which I talk about in the neurology section. So this is a very useful screening marker in pregnancy. Low levels suggest Down syndrome, high levels suggest a neural tube defect. The other 2 components of the quad screen are beta-HCG, just like is used in the first trimester, and inhibin A. Levels of these 2 substances are increased in pregnancy with fetal Down syndrome in the second trimester. Inhibin A is synthesized by the placenta, and in pregnancies associated with Down syndrome, more of that substance is secreted, and therefore more is found in the maternal blood. And that concludes our module on Down syndrome.